Good afternoon, everyone, and welcome at the Cochlear Science and Research Seminar on Effective Hearing Treatments for Healthy Aging. My name is Bart Volkaert, and I'm the Vice President, Clinical Affairs and Market Access for Cochlear in EMEA. It is my pleasure to introduce you to this 1-hour online seminar on this exciting topic, where experts from different fields will introduce you and share their insights on the evidence, the current state-of-the-art practices, as well as the future needs to offer more effective hearing treatment for healthy aging. But let's start indeed with reminding ourselves that this seminar is a forum for education and information sharing amongst research partners. The representations and views expressed in any presentation are those of the presenter and do not reflect the views of Cochlear. This seminar is nicely reflecting our mission at Cochlear to help people hear and be heard. The key opinion leaders will all introduce you and share with you on how the impact of, but also on how actually the solutions are contributing to a stronger empowerment of connecting people with others and live a full life. They will also discuss on how to transform the way people understand and treat hearing loss by means of introducing innovative hearing solutions. Very recently, some interesting publications came out on this specific topic and emphasizing the importance of effective hearing treatment. I'm referring here to the World Report on Hearing from the World Health Organization, emphasizing on some topics and the importance of some topics that will be discussed during this seminar, including to have an early as possible intervention, to look into the rehabilitation, to provide access to technology, including hearing aids and cochlear implants, and furthermore, also, and maybe most important, to improve communication across all ages, to facilitate participation in all activities. And this is exactly where this webinar is about. Furthermore, and even more recently, the CI task force has been developing the living guidelines, reaching consensus on the best effective hearing treatments by means of cochlear implantations for adults. And they identified different areas of evidence where more research is required. Not the least, and looking into the patient journey and looking into how the patient and the candidates are referred to a best solution. On the evaluation, the specialist evaluation and the rehabilitation. Now, during this seminar, we will talk about evidence, scientific evidence, and how this drives awareness and behavior change. If you want to know more about these topics, I'm kindly referring to the materials that are available as part of this seminar. And this brings me to the point to hand over to our two hosts, Professor Domenico Cuda and Dr. Isabelle Mosnier. Professor Cuda is the director of the otolaryngology department at the hospital in Piacenza in Italy, and he has been the president of the Italian Society of Otorhinolaryngology. Dr. Isabelle Mosnier is a director of the Center of Clinical Research in Audiology at the Pitié-Salpêtrière in Paris, and she is the deputy head at the Department of Otolaryngology and Head and Neck Surgery. Recently, she became president of the French Society of Audiology. So, Professor Cuda, Dr. Mosnier, the floor is yours.
Thank you. Thank you, Bart. Good day, everyone. Welcome to this seminar. First of all, let me thanks Cochlear Company, for honoring me with the invitation to this inspiring seminar. But let me show you an overview of this seminar. Basically, we planned two different sessions. In the first part, we'll be have three main lectures. One by my co-moderator, Isabelle Mesnier, regarding the relation between cognition and hearing loss. The second by myself, where I present the results of a multinational observational study. And finally, a lecture by Professor Lin on hearing aid and hearing loss and results on cognition of a clinical trial, a very relevant clinical trial, the ACHIEVE study. But let me just now go to some specific aspect on the background of this seminar. The main thing to say is that we have a high prevalence of hearing loss in the elderly population, but the problem is concentrated on serious consequences that they have, not only in the communication domain, but also in other aspects of quality of life, like increased false risk, increased healthcare use, including the number of hospitalization, drive limitation, depression, poor and social functioning, and especially the association with cognitive decline or dementia. So hearing loss affects all healthy aging targets, like independence, psychological well-being, and so on. The other question is that this population is an heterogeneous population. In fact, we have not only retired people, but also people who want to work. Some are very active, some have or want to contribute to family or social life. Some adapt successful to hearing loss, for example, with listening strategies, ambient modification, use of hearing device. Others no. There are someone with relevant comorbidity, others no, others are relatively healthy. So probably exist different phenotypes to consider when we speak about rehabilitation. The other question is that we have a lot of tools to rehabilitate this population. Technology, but not only technology like hearing aids, cochlear implants, other devices, assistive listening device, communication technology, but also program of rehabilitation, training, counseling, programs, group programs. The thing that we have to remark here is that no one-size-fits-all solution exists for these populations, but especially that probably we need for special program for patients with various stages of cognitive decline. The focus of the seminar is to update and discuss on new evidence, in particular evidence that came from observational studies, clinical trials, but also discussion on confounding factors of subgroups of this population and functional measurements. So at this point, it's a pleasure to me to give Isabelle Mesnier the microphone to speak about her lecture. Thank you, Isabelle.
Thanks a lot, Professor Kuba. It's an honor for me to be here. So, first of all, about dementia, 55 million people live with dementia in the world, and this number is expected to triple by 2050. And the World Health Organization explained that any intervention capable of preventing dementia or even delaying its onset or progression might have marked effect of the burden of the disease. Several studies established a strong association between hearing impairment and cognitive decline, and several studies have been published recent years, and the Lancet Commission of Dementia published that hearing loss is the highest potentially modifiable risk factors that may account for 8% of risk of dementia. But in all these studies, it was peripheral hearing loss, which has been studied using pure tone audiogram. The impact of central auditory deficit in the association between hearing loss and cognition is underestimated. Also, Gates et al. In 2010 shown that there was a tenfold increased risk of developing Alzheimer's disease in case of central auditory processing dysfunction. And a recent study of the same team showed that association reported between PTA and dementia risk may be because of impaired central auditory processing. So, moreover, there are now several studies showing that hearing impairment is associated with brain atrophy. And last year, a publication of the Lancet summarized the result of the UCAR Biobank study, which include more than 165,000 patients with a speech in nose test, and a big part of them underwent an MRI, and lower volume of cortical and subcortical regions and lower microstructural integrity of white matter tracts were associated with poor hearing performance. In the same paper, it has been shown that hearing impairment was associated with a higher level of tau protein in the CSF, and tau protein concentration in the CSF is highly correlated with tau deposit in the brain and occurs a decade before dementia. So there are probably multiple mechanisms underlying the association between hearing loss and dementia. First of all, the sensorineural deprivation leads to social isolation, reduced activities, depression, and brain structure changes, which are risk factors of cognitive decline. Moreover, in hearing impaired patients, the effort required to maintain communication leads to a cognitive load that results in smaller pool of resources available for other cognitive tasks. But recent studies suggest a shared neurodegenerative process with tau accumulation in the brain, even though confounding factors of dementia and hearing impairment were adjusted for statistically in epidemiological studies. So now what about our CI candidates? Studies show the greater risk of cognitive disorders and dementia in case of more severe hearing impairment, but at the same time, our CI candidates, they are usually in very good health and not representative of the global population of the same age. I identified last year 24 studies on the topic of cognition in older CI candidates, but most of these studies, they analyze the evolution of neurocognitive performance after cochlear implantation. Only 3 studies compared the cognition with normal hearing subjects, showing that CI candidates, they outperformed in all or several cognitive subdomains. And only 2 studies compared younger and older CI candidates, showing that younger patients had obtained better cognitive scores. In France, we performed a multicentric study with 94 patients, and we observed that half our CI candidates, half of them, they had a mild cognitive impairment before implantation, compared to 5 to 19% in the global population. So now what about the result of cochlear implantation on cognition? There are several review and meta-analysis on that topic. So I will show the result of the meta-analysis published last year with 16 studies included, and you see that there is a small number of patients, and they conclude that there was a significant improvement of cognitive abilities in 12 studies, mainly for attention and executive function. And due to the small number of the participants and the small follow-up of approximately 1 year, they conclude also that well-designed studies with longer follow-up are necessary. But in the study comparing CI recipient and normal hearing listeners, CI users obtain the same level of cognition as normal hearing subjects at 1 year after implantation. So now what about our French studies? In the global population, when you have an MCI, you have 50% risk of developing dementia 5 years later, whereas in the global in our population, only 6% of the patients with MCI became dement 7 years later. All the patients remain stable or improved their hearing, and the improvement of cognitive abilities concern mainly executive function and attention. So to conclude, improvement in social interactions, depressive symptoms, and reduced cognitive overload could explain in part the short-term improvement of cognition. So older patients with severe and profound hearing loss must be implanted as early as possible to prevent an evolution to mild cognitive disorder, or in case of mild cognitive disorder, the patient must be implanted to avoid an evolution to dementia. But some points remains to be elucidated. The brain structural changes and the central auditory processing before cochlear implantation, the evolution of brain structure after cochlear implantation, the long-term cognitive changes in our CI recipients, the nature of the cognitive impairment in that population. Perhaps there is an interest of blood biomarkers used, and the cognition in younger adult CI candidates. We performed a study in my department to analyze that point. Thank you for your attention.
Thank you, Isabelle. So this is a study, a multinational observational study on healthy aging in elderly cochlear implant recipient. These here are listed are co-authors. So it's a study performed in 4 different countries: France, Italy, Israel, and Spain. The study was prospective, study repeated measure. An evaluation was performed preoperatively, and then 12 and 18 months after the treatment. So 4 main domains were explored. So this is not a study on just related on auditory performance, but were explored general health issues, physical issues, also hearing issues, of course, in this domain, social and mental issues also. 3 groups were included here: a relatively young group, 60 to 64, 65 to 74, and then 75 to 91. So these 3 subgroups were relatively well distributed across this sample. We have to say that this was a relatively healthy population. Most of them were active in terms of activity, daily activity, living in a city, high instruction level, and good style life with no smokers, alcohol consumption, a relatively healthy population. But let me show you main results. Here we can observe the HUI index, the Health Utility Index. Is a multi-attribute index that improved significantly between baseline and postoperative visit in a very significant way. We can observe here in all subgroups the improvement in terms of HUI-3 index. There was no significant effect of age groups you can see in the slide, and the increase was especially significant, of course, in single attribute hearing and speech scores of this questionnaire. That is a general quality of life questionnaire, of course. Clinicians reported the hearing and communication since of the special group examined, and also since different socio-cultural area, different languages and so on, we decided to examine the category of auditory performance scored by clinicians. This CAP consider functional auditory skills. The rating is completed by clinicians, and as you know, it can vary between 0 and 9. Higher score indicates, of course, higher auditory skill. We can observe here the mean evolution of this score. All subjects obtained or maintained a CAP over 4, representing ability to discriminate speech sounds. So this is in line with the expectance, of course. When we consider the self-report on hearing and communication, we can observe that on average, handicap reduced from significant handicap to the mild to moderate handicap, no difference between 12 and 18 months. This was scored by means of the HHIE questionnaire, the hearing handicap inventory in elderly. Dependence. This is another important quality of life aspect evaluated by instrumental activities of daily living scores that improved significantly between baseline and postoperative visit. You can observe on the graphs the amount of this improvement. So a significant shift to a greater independence was reported post-op compared to pre-op. Most of the shift, of course, was due to an improved ability to use telephone. Social and emotional isolation, evaluated with the Young Loneliness Scale, score were significantly reduced between baseline and 80-month visit. So the proportion of subjects classified as lonely reduced between baseline and postoperative visit. We can observe here the increase in the green bars. Summary. Health-related quality of life, perceived hearing impairment, hearing performance, and independence improved significantly. Subject reported being less lonely. SSQ and speech recognition scores improved significantly between baseline and postoperative visit as expected. We saw no significant change in depression or cognitive function, but in general, subjects were not depressed or cognitively impaired at baseline. In conclusion, cochlear implantation produced clinically significant improvement in health-related quality of life in all adults, regardless of age group, even over 75 years. Better hearing not only improved individuals' ability to communicate verbally, but also their ability to function independently. Subjects felt less lonely and felt less disabled when their hearing loss. By their hearing loss, cochlear implants contribute to overall well-being for healthy aging. It should be considered as a routine treatment option for those over 60 years with bilateral, moderately severe, profound hearing loss. Advanced age is not a barrier to cochlear implantation. And so let's now move on to the reading by Professor Frank Lin from Baltimore.
Good afternoon, everyone, and I want to thank the organizers for inviting me to present to you. What I'll be sharing over the next 8 minutes is specifically the results of the ACHIEVE trial, which I'll introduce in the next few slides. So I need to first mention that I am presenting on behalf of a much larger group. The ACHIEVE trial represents the results of nearly 10 years of work, sourced from 8 universities across the United States, funded for many years through the National Institute on Aging, which is a U.S. government funder in the United States. So the thing that guides all this research is essentially this model here, which some of you may have seen, and that was introduced before by Professor Mosnier, where we have different mechanisms that link hearing with a greater risk of cognitive decline or dementia. And interestingly, of course, then our interventions, namely things like simply as simple as a hearing aid, could potentially modify these pathways and potentially reduce the risk of dementia. That finally brings up the idea of the potential role for hearing intervention in reducing the risk of cognitive decline and dementia in late life, which is really important because many of the other critical risk factors are things like early life education or, for example, midlife diabetes. But you can't do something about that now when someone's presenting to you when they're 70 or 75 years old. So the goal of the ACHIEVE trial was to ask a very, very simple question, namely, if we treat hearing loss, can we in fact reduce cognitive decline, cognitive loss, within just 3 years, relatively a short period of time. So this is called the ACHIEVE trial, the Aging and Cognitive Health Evaluation Elder Study. The main outcome of the ACHIEVE trial is looking at cognitive decline, which I'll share with you today. And also share with you today some of the preliminary results now we also have on brain structural based on MRI data, which we have on a half sample of participants at baseline and 3 years later, looking at effects of hearing intervention on changes in terms of cortical thinning, which I'll introduce. So the design of the ACHIEVE trial is actually relatively simple. Nearly over a 2-year period, we recruited nearly 1,000 older adults, 977 older adults. These are all older adults who are 70 to 84 years old. They had untreated mild to moderate levels of hearing loss, basically a pure tone average between 30 and 70 dB. So the standard range for where you would typically consider a conventional amplification. And they all essentially were cognitively intact. Now, interestingly, the people in the ACHIEVE trial came from 2 different study populations. We recruited about a quarter of the sample from existing participants who had been followed for many years in a study looking at heart health, people who were recruited in midlife from a random sample of the population and has been followed to the present day to look at basically how they develop cardiovascular health outcomes as they age. But they were essentially a random sample of the population. The other 3/4 of the cohort came from new healthy community volunteers, new volunteers responding to advertisements about a new healthy aging study. These are people who respond to Facebook ads, for instance. Now, that comprised 1,000 people. They were then randomized, either getting best practice hearing intervention or a successful aging health control, education control intervention, basically not getting their hearing treated directly. And then they're then followed every year thereafter for 3 years, and we're looking at cognitive decline over 3 years. Now, the main, this ACHIEVE study I mentioned before, came from 2 different study populations, and the reason why I did that is we based this trial within the existing infrastructure called the ARIC study, the Atherosclerosis Risk and Community Studies, and this is a large population of older adults followed for many, many years. They came from a random sample of the U.S. population when they're initially recruited, versus the de novo cohort, new healthy volunteers responding to Facebook advertisements and things like that. You can imagine at baseline, the de novo cohort had fewer risk factors for cognitive decline, mainly because they're very, very healthy. These are healthy older adults who are very interested in a cognitive study and they joined the study, hence are very different than a random sample of the population. Now, if I show you the main results, this is the combined results after 3 years, and when we combine the ARIC and the de novo cohorts, what you see is for the primary outcome of global cognition is measured through a 10-item or a 10-test neurocognitive evaluation. It's about an hour to administer. The majority of tests are non-auditory tests. So someone's not doing better or poorly because it's auditory. These are all primarily non-auditory tests of cognition. What we see after 3 years, the control group, they decline about 0.202 standard deviation units in cognition. Intervention group changes the same. So on face value, there appears to be no effect of hearing intervention on reducing 3-year cognitive change. Now, what gets more interesting, though, is a pre-specified sensitivity analysis, which we always planned, was to look at the results separately within the ARIC cohort, the random sample of the population, versus the very, very healthy de novo cohort. When you look at these results, you see a very, very different result. You see in the ARIC cohort that the hearing intervention was associated with nearly a 50%, 48% reduction in 3-year global cognitive, so a very substantial reduction in 3-year cognitive loss. And you see that trickle down to 3 cognitive domains as well. Whereas if you look at the de novo cohort, the very healthy volunteers, you see no effect of hearing intervention. So why do we see such big differences? And it's because of this. If you look a little more closely at the data, you look in the de novo cohort, the control participants who got no hearing intervention, versus the control participants in the error cohort. You see on average the de novo cohort, their 3-year rate of cognitive change among the controls was about 3 times slower, right? And this makes sense. Again, if you have very, very healthy new volunteers, they don't decline much over 3 years. So if they're not declining very much over 3 years, you can't slow down something that's already not going down at all, right? So in contrast, the random sample of the cohort having a much relatively steeper rate of cognitive change, 0.402 standard deviation units over 3 years, there's actually room there to slow that down further. Whereas the very healthy volunteers, you're not going to see effect, or we could not see effect within just 3 years, because they're not declining within 3 years. They're too healthy. Again, versus the random sample of the population, a much more moderate rate of cognitive decline. There's actually room to reduce that decline and detect it within just a 3-year period. More interesting, I'll tell you, this is a very quick summary. We also did a half sample of the cohort, about 445 people also got an MRI scan at baseline, and 3 years later, there's a 3 Tesla MRI scan. These are looking at cortical thickness of all the different sub-regions of the brain. Wherever you're seeing red is where you're seeing reduced cortical thinning over 3 years with a hearing intervention versus the control. So I'll be honest, we didn't think we see anything on the brain MRI data within just 3 years. But already you're seeing actually pretty strong effects and a very strong signal of reduced cortical thinning within just 3 years with a hearing intervention versus the control. Particularly where you're seeing, interestingly, is actually not the temporal lobe. You're seeing it particularly the bright red spot here in the front. That's the pars orbitalis, the critical area for language and speech processing. You're also seeing very strong effects throughout the cingulate cortex, the relay station in the brain that helps maintain cognitive control, as well as is sort of the central hub for a lot of sensory afferents as well. So we're seeing very clear reduced cortical thinning in those areas within just 3 years, actually, with the hearing intervention, which is actually not what we anticipated seeing within just 3 years. So a few key findings. We see after 3 years in the ACHIEVE trial a very high adherence and satisfaction with hearing intervention. I didn't show this data, but we're seeing very high rates of hearing aid use as well as performance on communication improvements. We see strong effects of hearing intervention, 48% reduction within just 3 years, especially from the ERIC cohort. That was a sample that came from the random sample of the US population. These results are published in The Lancet in July 2023. Our exploratory MRI analyses showing a clear biomarker effect of hearing intervention on reducing cortical thinning within just 3 years as well. Key inference, hearing intervention may reduce cognitive loss within 3 years for populations of older adults at risk for cognitive decline. If they're very low risk, you're not going to be able to see it within 3 years. If they're actually at risk, we think you're likely seeing it within 3 years. There's actually some room there to actually slow something down within 3 years. I was mentioning again, the funding for this trial all came, fortunately, from the National Institutes of Health. All the hearing aids for this trial were donated by Sonova kindly. The NIH will not fund devices. They'll fund for the trial and the effort, but they don't want to fund devices. Sonova was kind enough to donate all the devices that are used in the study. And then I'll finish up here. And again, this is the cover of the Lancet, which I thought was quite telling how they put this on the cover, showing that that addressing hearing loss may in fact be one of the most critical risk factors for reducing the global burden of dementia. Thank you very much.
Thank you, Professor Lee. And now we move in the second part of the seminar, the panel discussion. We have prestigious panelists to discuss, in particular, a specific aspect of the problem. I will start asking something to Dr. Archbold, Sue Archbold from Nottingham. Hi. Hi, Sue.
Hi. Hi, thank you.
In the developed world, the population is aging, and we should aim to keep the elderly population in good health. But how would you define healthy aging?
Thank you. And thank you for the introduction and being able to participate in this wonderful seminar, and everybody for the wonderful data and information we've already shared. I'm not going to add to the data, but I'm going to share some thoughts about healthy aging as you asked me to define it. So as I grow older, and as I observe people around me growing even older, defining healthy aging doesn't mean simply staying alive, as the Bee Gees told us, if you can, sang to us, if you can remember that, or counting the years as success. I've learned an awful lot from this neighbor of mine, Rosemary. She had meningitis. She had an implant in her 70s. She's blind. She's got arthritis. She has a husband with dementia. In spite of all that, she really tells me lessons about healthy aging, in spite of the fact she's not actually very healthy. So, for me, healthy aging means communicating and making our own choices for what we want as we age. And all of us here are really interested, of course, in hearing. And for us, how we do that, hearing would be crucial to how we are able to communicate and make our own choices. But we're discussing within the field of hearing where we all spend so much time. And if we were in different groups, there might be a completely different focus. People would be talking about don't drinking, don't smoke, don't exercise more, keep to a healthy weight, socialize, keep the brain going, keep active. But we're all here to think about hearing, which we all value. But maybe we need to think about our thinking in that larger context, the larger context where all these other issues are so important, but where hearing is low on the list. In spite of hearing being so crucial to healthy aging, and in spite of the years lived with disability after the age of 70, hearing being the greatest cause, in spite of all that, in spite of all we know, in spite of all that's being shared, still, people aren't addressing their hearing loss as they grow older. People aren't taking action. We know from the great Eurotrack studies from AHIMA that people don't know about cochlear implants, even after all this work and even after over 30 years. In the studies in Germany, France, the UK, the majority of the population don't know about cochlear implants, and people who've got a severe to a profound loss are not being referred. So it seems to me that in spite of all we know, we still have a great job to do about educating people that hearing is a crucial element of healthy aging. Thank you, and I look forward to hearing what the rest of the panelists are going to tell us. Thank you.
Thank you, Sue. I have to ask to Professor Lin. Professor Lin, the ACHIEVE study focused on testing a hearing intervention involving basically hearing aids, given the study population had mild to moderate hearing loss. But what you think the ACHIEVE results can mean for those individuals with more severe form of hearing loss where a cochlear implant may be indicated?
Professor Kuta, thank you so much for that incredibly important question. But I'll start by saying, I think for any time we ever make a clinical recommendation to a patient, it always requires extrapolation of scientific results to the individual clinical situation, right? So no person ever represents directly who was studying a clinical trial. At the same time, we have to extrapolate scientific results to the actual clinical patient sitting in front of us. We also have to balance the risks versus the benefits of what we're recommending, right? And it also has to be based within the context of our scientific knowledge of what the intervention does, right? So I think there are two situations where this comes up. Even when we get the cochlear implant patients, when I see a patient in my clinic, let's say a 75-year-old woman who says, you know, I have a mild hearing loss, do you think I need to do something about it? I always frame in terms of risk versus benefit. The risk of let's say, a hearing aid for her is essentially zero, right? There's no medical risk with a hearing aid. The benefits, I would say, they're very clear, immediate benefits of improving speech, communication, sound awareness, things like that. And then usually what I'll do then too, I'll mention that there may be possible cognitive benefits on supporting cognitive health. You can never generalize direct an individual. So everything I do is always extrapolating scientific results to the given situation and then risk versus benefit. So I think that's a pretty easy suggestion to make because the risk-benefit calculus is so high. I think when we go to things like cochlear implantation, it's very much the same idea, right? This ACHIEVE trial did not directly study cochlear implantation, obviously. I think it's very hard to do a true randomized trial to ever be extended 3 to 5 years. It's very hard to randomize that far out. But if we believe that there are mechanisms that link hearing with cognitive decline dementia, that a hearing intervention can modify those pathways. I think is very, very clear now. And for people who are still struggling, let's say with hearing aids because they have a very severe loss, there's clearly evidence there that the hearing aid's not doing enough to benefit them in terms of social engagement, things like that. That every reason suggests that a cochlear implant could likely modify those pathways and reduce risk as well. So I think for me, when I see those patients, it comes down to extrapolating risk versus benefit. The risk of a CI, I would say, in the hands of a trained surgeon at a center is, I don't want to say zero, but quite low, quite simply. And the benefits are also very clear. And I start with the more tangible benefits: speech, communication, social engagement, safety. That's without a doubt. And then layered on to that, I'll say, and there also is likely good evidence to suggest that it could support cognitive health in the long term as well, right? So I think for anything, any trial, any clinical patient we see is always requires extrapolation and it always requires balancing of risk versus benefit.
Okay, thank you. Very interesting discussion. I have to ask to Professor Fettoni, Anna Rita Fettoni from Naples University, who gained a lot of experience in animal experiments. Professor Fettoni, could you elaborate on what your learnings are regarding physiopathology behind the coupling between hearing loss and cognitive decline?
I believe that the experimental model could be very interesting in considering the relationship between cognitive decline and hearing impairment. We know well that there are several hypotheses relating the cognitive decline and the hearing loss, the common pathology, the mechanism of the unparished input from the periphery to the central auditory cortex and the other sensory cortices, or the concept that it could be an increased listening effort in the aging patients, and the new mechanism suggesting the real relationship between the molecular mechanism leading to, for example, the neurodegenerative diseases such as Alzheimer's disease and the pathology in the auditory cortex in the brain. We studied in our lab considering that the hearing loss is in the time course of the evolution to dementia as a critical factor in the mid-age. We studied the animal model in corresponding age, in the mature age, in the mid-age. In two animal models, the normal, the wild-type model, which is the animal model C5-7, which is a model of a normal hearing process during life, and the model of the Alzheimer's disease, inducing in the mid-age hearing loss induced by noise. And we demonstrate that there are the mechanism of the common pathology, vascular common pathology in the periphery, in the stria vascularis, demonstrating that there is a degeneration of vessels during the mid-age. But we also observe that there is a degeneration of the fibers, spiral ganglion neurons, indicating that there is a processes of the sensorial and neural damage. But it's very interesting that in our model, we also demonstrated that not only in the Alzheimer's disease animal model, but also in the wild type, there is in the hippocampal region a damage induced by increased biomarkers expression. So we demonstrated that there is a significant decrease of spine densities in the primary auditory cortex and in hippocampus, and also in with an increase of the biomarkers of the ROS production, oxidative stress markers, and also in the cochlea, we demonstrated that there are an increase of the biomarkers, typical biomarkers for Alzheimer's disease degeneration, such as the tau, such as the alpha amyloids. And finally, we demonstrated that sensory deprivation accelerates learning and memory defect in the Alzheimer's disease animal model. So in conclusion, the animal model are useful to really demonstrate the relationship between cognitive decline in a model of the hearing degeneration, hearing impairment, based on the mechanism of the neuroinflammation and redox imbalance, not only in the periphery, not only in the cochlea, but also in the primary auditory cortex and the hippocampus, that is the structure mainly involved in the processes of the memory and in the executive function activities. Thank you so much.
Thank you, Anna Rita, highlighting this important consideration, pathophysiologic pathway that could explain the relationship between hearing loss and cognitive decline. I invite Isabelle Mosnier to continue supporting the panel discussion, and I have to thank all panelist members for the cooperation and the precious cooperation for this discussion.
Thank you, Professor Kuda. So the next question is for Dr. Huber from Salzburg. Does auditory rehabilitation improve cognition, and is cognitive decline really reversible?
Thank you very much. There is a consensus paper that was published in 2020, the statement that the use of cochlear implants may improve cognition in older adults with bilateral severe to profound sensorineural hearing loss was approved by 77.3% of the Delphi panel. Then there are two recently published systematic reviews and meta-analyses that conclude that cognitive performance was improved after auditory rehabilitation. However, the effect sizes were only small. Now I come to the second part of your question. I would like to refer to our cohort study published in 2021 with the main result that the cognitive decline after CI could be partially reversed. Please note that the non-inferiority statistic is required to verify equivalence. Equivalence cannot be tested via t-tests or ANOVAs. Finally, I come back to the review by Yeo et al. 2023. The authors informs that hearing aid and CI reduce the risk for any cognitive decline by 19%. Thank you.
Thank you, Professor Dr. Huber. So the uptake of cochlear implant is as a treatment option in the elderly faces a wide range of obstacles. So I would ask to Professor Bellemin from Paris. You are the head of the geriatric department. Can you give us any insight into your ideas on how to overcome the lack of awareness as well as the barriers to referral for CI in the geriatric wards?
Thank you, Isabelle. In fact, there are many obstacles to overcome in optimizing the modern management of hearing loss in older adults. First of all, there is a large defeatism from the patients, from their proxies, and sometimes, I would say often, from healthcare professionals themselves, and especially when standard hearing aids have been tried without success. So this is the first point to fight. In my view, the second one is that the cochlear implant approach is not well known to general practitioner or to geriatrician, and it's often considered to be reserved for children with profound hearing loss, and the use in adults, even in older adults, is not known by many primary care physicians. The third point is, of course, the cost and the fact that cognitive impairment are also perceived as a strong limitation for cochlear implantation. So I would say to move on and to provide a better chance to older adults to have a better quality of life and to keep functioning, a good functioning. The first is the better information for patients and healthcare professionals, including geriatricians and general practitioners, and also to facilitate the referral of all the patients to the specialized centers, especially when a standard treatment fails. And also it's important to elaborate care pathways, well-organized care pathway to facilitate referral of the patients.
Thank you. Thanks a lot, Joël. We're trying to do that in Paris, but it's a big job. So we need also to demonstrate the success of treatment in the elderly receiving cochlear implant. So Dr. Simres Franklin, you work in Dublin. What outcome measures are important in the elderly?
Thank you very much. Yes, it's very important to consider outcome measures in the elderly, and it's important to look at different categories of outcome measures. And firstly, audiological measures to ensure that the patient is having access to a range of sounds that allow them to understand speech, to listen to speech, to engage in conversation. So aided PTAs, listening skills, and word and sentence testing, both in quiet and in noise. Another audiological measure that can be used is device usage, and a lot of the manufacturers give us this information. And it also gives us information on how the patient is using the device, in which environments they are using the device, and if they are using the device for a considerable portion of their day, it means that they are getting benefit from the device. So that's very reassuring to know that. Another category of outcome measures is cognitive measures, and those are particularly important in the elderly. Cognitive screening pre-cochlear implantation is important to ensure that the patient understands the process, that the patient is able to consent, but also to level the expectations of what we can achieve with the cochlear implantation and with the technology. And compare these pre and post cognitive screening results is important to see, like the other panelists have said, how the cognition has improved, but also in which subdomains they have improved. But other measures are also important, like listening fatigue and listening effort. The whole idea of providing the technology is to create an easiness of listening, is that the listening is not taxing, and there is this cognitive resources still there for the person to elaborate on what they are listening and to have those cognitive spare capacities that are important for so many other things. So all those measures of fatigue and listening effort are important to ensure that also the device is programmed optimally to minimize those listening effort and optimize the cognitive capacity. Finally, socio-emotional measures are also very important, and these are patient-reported outcome measures. And they are really about goals and expectations. What are the goals prior to surgery? What are the expectations of the patient? And are they being met after the implantation? How did quality of life change? Is there a perception, a subjective perception of an improved quality of life, quality of hearing, and also music appreciation? In our elderly population, a lot of our patients are looking to reconnect to music. Music brings so much of that emotional connection and that social connection as well. So it's important as well to look at music appreciation and ensure that if it is part of their goals, that they are reconnecting with that important part of emotional well-being.
Thank you, Dr. Simoes.
Thank you.
And now let's not forget about the opinions of the patients. So, Dr. Harbold, what is and should be included in the health technology assessment of CI from the user's point of view, and how can CI users themselves be involved?
So thank you very much, Christina, who gave a lovely starter for me trying to answer this question about health technology assessment from the user's point of view. You gave us a great overview of some of the issues that need to be addressed and that needed to be included in this. So if we have a look at the right-hand side, you can see in the top two images that we have there, a range of people who consider themselves users. We've got Rebecca at the top, implanted at 3, with her son implanted at 7 months old. We've got Kers and we've got Dr. Seidler from Germany, both implant users, all of whom expect to be involved in their own assessment of how they're doing and in their choices that they make about their technologies. I don't really quite understand how we can assess hearing health technologies without involving the user or the recipient, as the goal of health technologies and the developing health technologies is to improve their lives. But of course, outcomes are different for different people, and outcomes are the most important outcomes will be different for different people too. So the World Health Organization's World Report on Hearing advised that users and those with hearing loss should be involved before developing technology and during the development, rather than only when assessing it. And so that is really important, that user-driven technologies will then come with the outcomes that are important to the users themselves. And people now expect to be involved in their own health decisions. As the technology has changed, as the exciting technologies, particularly of cochlear implants, has changed over the last 30 years, so has society. And people expect to be involved in their own healthcare decisions, to make their own decisions, and have the information on which to do so, as Dr. Lin explained to us how he would go about that. Particularly after the pandemic, people have got very used to assessing public health information, statistics, to question them. They wish to be involved in their own decisions and to think about their own health decisions in that way. And that's particularly true, I think, as they get older. At the bottom, you can see the European Disability Forum, where the European cochlear implant users have a great role in advocating for cochlear implant users at the European level. And their slogan is, "Nothing about us without us." Involve us in any discussions of our care, any discussions of the technology and how we use it and how effective it is. And thinking about involving cochlear implant users, when we were looking at the living guidelines and the development of the living guidelines for adults with cochlear implantation and looking at the recommendations, we had users from all over the world on Kicker Conversations, looking at what they thought was important. And what they felt to be was important were the functional outcomes, the outcomes that Christina was talking about, the quality of life outcomes, the changes that they're seeing in quality of life. And particularly, one of the things they brought up was the involvement of peer groups that were so important to them. So you can have a look at those recommendations, of course, from the living guidelines, which are really important to thinking about how we assess hearing technology and go on to do so. But also, we've recently published a report called Cochlear Implant Services Matter, a survey of over 1,000 cochlear implant users from 40 countries, telling us what matters to them. And again, they come up with those functional outcomes and the difference that cochlear implants really make to them in everyday life, and seeing how we can capture those. And if we capture those, we can then make the public and those who could benefit from cochlear implants but aren't receiving the information, make them aware of the benefits that they could receive if they went forward with cochlear implants. So thank you to everybody for all the great information we've had today and the difference that it's really making to adults the world over, including, as we saw, those who are elderly. Thank you, everybody.
Thank you, Dr. Arbol. It's a very important message. So many thanks to all the panelists for joining us. It was a very beautiful panel. Thank you.
Thank you. Thank you.
So to conclude, 4 take-home messages. So first of all, the managing hearing well is key to healthy aging and contributes to cognitive health in older adults. Second message, a heterogeneous population requires precision and experimental audiology, including relevant outcome measures with real-life relevance. You see that cochlear implant can only partially reverse cognitive decline, so we can given a realistic counseling and referral to patients. And then people and families must be involved in their own care decisions and have the info to do so. Just to finish, the topic of cognition in elderly, it's one of the major topics of the next World Congress of Audiology, which will take place in September 2024 in Paris, just after the Olympic Games. So registration are open. You can submit some abstract. So save the date and visit Paris in September. It's a beautiful weather, beautiful time. Thank you for all to join this meeting, and thank you for Cochlear. It was for me an honor to be one of the hosts of this meeting. Thank you very much.
Thank you, and goodbye, everyone.